Good evening, everyone. Welcome to our Better Billing webinar series. This one is on care plans for nursing staff, creating perfect goals. My name's Helene. I'm the Workforce Development Officer here at West Vic PHN. I'll be the facilitator for this evening, and alongside me is Jade, also Workforce Development Officer. I'd like to begin by acknowledging the traditional owners and custodians of our unceded lands and waterways. I'm dialing in from Wadawurrung country this evening. We recognise their resilience, diversity, and the ongoing place that First People hold in our community. You can view the majority of our webinar recordings freely on our Learn YouTube channel, and the link to that is up on the screen at the moment and in the chat. Please see our upcoming events on the screen now, and you can register for these via our website, which the link is also there. We're very excited to announce our annual conference has been set. Please see the date for this conference, which will be held again at the stunning Goodshed in Ballarat. Also, please take note of the West Vic PHN health pathways relating to this topic, and that's on the screen at the moment. A certificate of attendance will be emailed to everyone. So if you could take a moment just to check that your full name is displayed accurately on the screen. If not, or if you're not sure, just rename yourself so that we can get your certificate emailed to you. Just pop your first and last name in the chat box. And if you could keep yourself on mute, unless you would like to ask a question, we do encourage interactivity and discussion. So please feel free to type questions in the chat box at any time, or take yourself off mute and ask these questions at the end of the session. Your feedback's important. So if you could just complete the event survey after the webinar. There's a link there, and I'll just give you a little reminder after the presentation. So let's get right on to it. And our presenter for this evening, again, is Dr. Ashley van Leeuwestyn from Better Billing. Welcome, Ashley, and I'll hand over to you.
Thanks, Helene. Okay, so let me just share my screen. So I am Dr. Ash van Leeuwestyn. I'm a GP reg for 11 more weeks, and then I'm finished. And I am the owner and creator of Better Billing, which is an online MBS education website that focuses predominantly on providing courses for GPs, nursing staff, practice admin, and practice managers on Medicare billing, as well as individual practice support that I offer for specific practices, and then also webinar and presentation stuff that I do here with the PHN, as well as our other presentations that you might see us do face-to-face. So tonight I'm focusing predominantly on what I call powerful nurses, and nurses in general practice are some of our most powerful assets. And so my focus tonight is mostly on goal setting around care plan creation, the role of the nurse in the care plan creation, and also about the use of appropriate 10997 and 10987, and we'll go through that in a little bit more depth. So this presentation is, it's not particularly too long. It's going to get straight to the point, and hopefully gives you some good resources that you can take afterwards. I do encourage you that at the end there is some question slide. There's a question point at the end, which I'm happy to answer any of those questions if you'd like to do it via the chat, or if you'd like to do it turning off mute. You're very welcome to add in more questions in the chat as I go. If I ask certain things and you'd like me to re-explain it, then feel free to do that then. So what we'll do is we'll get cracking. So the content of today, so like I mentioned, the first thing we're going to be focusing on is goal creation for care plans. And then we're also going to be looking at 10997 and 10987. And then we're going to be having a look at some billing opportunities when nurses are seeing patients, and when they're finding patients to be reviewing, etc., or after they're doing their care plans. So we'll have a look at a few different options, and we'll run some patient examples so that you can sort of see what I'm talking about and looking at the options. So care plans, obviously this is one of my most popular topics, and it's for a really good reason. I think while we all do care plans, and it's really important for our practices financially It's also a great resource for patients to actually use on a regular basis. And as GPs, it's a really important item number for us. It's one of our bread and butters. So when I have a look at care plans, I touch base a little bit on eligibility. And so patient eligibility for care plans is mostly, looking at patients who have had chronic disease with a condition that will last 6 months. So a lot of people will ask me, what is a chronic condition? How can I decide that this is something that the patient has got as a chronic condition? Not as simple as diabetes or hypertension, whatever that might be. How can I know? And the most important way to see this, and from a Medicare point of view, is that condition will last 6 months or has already lasted 6 months. Another thing about eligibility for care plans at the moment is the patient in the community needs to be either in the community or at a private inpatient being discharged. So public hospital patients do not qualify, and RACF patients also don't qualify because they access the 731. Okay. Now, 721, 723, or care plans, as I call them interchangeably, are frequently done every 12 months with your reviews, which is your 732 review every 3 months. Okay. So I'm going to have a look at what I would sort of say is a good or a bad care plan option, or how we can do our care plans in a way that are done well and those that are done poorly. In a lot of my practice support work, quite often I will have a look at the care plans and just pull them out at random just to see what the quality is like. And sometimes they're okay, and sometimes they're really not okay. And there's some really common things and common mistakes with them that I try to teach in these talks. So the first is about the goal format, and SMART goals are absolutely still gold standard. Now we'll go through a little bit on SMART format goals and what they sort of look like. But then a lot of practices, for instance, might use one-word goals or one short goal. So for example, that might be lose weight, walk more, blood test, whatever it might be, or those goals as a patient is seeing you for a care plan. A SMART format goal is something that definitely requires time, and you also actually have to think a little bit on this. It's not about clicking sort of buttons, and that should stem ultimately from the GP passing it on to the nursing staff as to the importance of what they want as their goal. Goal numbers, how many goals you have, are not important. What you need to do is have one actual goal, at least one. If you want to have two, that's absolutely fine. If you want to have three, great SMART goals, go for it. However, there's nothing wrong with this, but I particularly like to have one goal so that I can see that one goal is measurable during the time that I'm doing reviews. Some care plans that I have seen have no goals, and they've just got lots and lots of tasks, and they are not Medicare compliant and absolutely would not pass auditing. Okay. Then I have a look at tasks, and looking at tasks when you create the care plan, whatever is required. So that might be the podiatry review, that might be diabetes education, that might be the pharmacist doing a medication review, whatever that might be. It might be the patient going back to the gym twice a week. You can have as many tasks as you want, as long as there are tasks and they're relevant to the goal. That's the most important part. If you have no tasks, but you have a goal, it's not considered a Medicare compliant care plan. Okay. Then a little bit of a word on TCAs, or care providers. So obviously I put a little exclamation mark here because a lot has sort of changed with team care providers or team care arrangements, and a lot is going to be changing. So we obviously don't have any confirmation of what the new care plans are going to look like just as of yet. We're waiting any day. Initially, we were told it's going to be July. We're not sure what that's going to look like. However, recently, notably, I found it was towards the end of last year, the team care arrangement Medicare criteria changed. So I'll go through what the requirements are in a team care arrangement, and that is still the GP plus two. So that might be the GP and the pharmacist and the dietitian, and it might be the GP, the cardiologist, and the dietitian. You do not need a specialist. So there was very common rumors of you have to have a specialist to have a care plan, which is absolutely not true. You can have your physio and your dietitian, a podiatrist and a diabetes educator. These are absolutely appropriate, and it's totally fine. You do not technically have to add in every single care provider that that patient has seen. I mean, we've all got complex patients that have seen nearly every specialty between now and, you know, within a 100K radius in the last 10 years. And sometimes you just do not have the space. And also it may not be relevant to add them to your care plan. So just because they've seen them within the last 10 years does not mean they need to be added. However, you still need to be able to fit the team care arrangement review, which is having the GP and at least 2 other providers. A poor care plan or a poor TCA would be that there would be no providers. And in that case, you can't be billing or processing a team care arrangement. It needs to fit that criteria. One common question that I absolutely know I will be asked, and so I mentioned it early, is about holding the billing until you get the signature complete. And it's a really hard question to answer because I know we've been doing this for a really long time where we've been holding the billing for 723 until our care providers provide the signature to say, happy to be a part of the team. In recent times with Medicare's MBS Online, you're very welcome to have a look. It has since removed the need to have signatures prior to billing the 723. I have a lot of clients who are still quite scared to bill the TCA without having co-consents or their consent forms back, and I think that's absolutely fine. However, as of the new changes of Medicare's care plans, from what we do know is that team care arrangements will be abolished. And that is the plan, is that they're no longer going to be a big part of annoying paperwork, which is great. And hopefully what we'll sort of see in our actual next talk, which is due after the arrangement of what the new care plans look like, we can have a little bit of a chat more about it. However, at present, in terms of current Medicare guidelines, there hasn't been a need for a signature. And so please be wary of that when you're really chasing down someone for hours of time, trying to get a signature from one specific physio or one specific diabetes educator, that has recently changed. Okay, so I've just got the first survey here. So Jade or Helene, if you guys don't mind popping it up. So these are just completely anonymous. So I believe they're anonymous. So what I'd really like you to add on this first little poll is telling me, when you guys are creating care plan goals at your practice, do you focus on a large number of short goals, 1 or 2 goals, or we often don't add goals? So it doesn't matter what the answer is. You're not going to get dobbed in. I'm not going to pull you up. I just want to know, what is the majority of things that you're doing? Are you on best practice choosing lots of those goals like maintain health, maintain foot health, maintain independence, lose weight, etc., which, I mean, we've all been there, we've all done that? Or are you doing 1 to 2 goals, or do you guys just not really add goals in at all? So if you can submit that for me and then see what it looks like. Okay, cool. So awesome. So mostly focusing on 1 to 2 goals, which is awesome. And there's about 13% of us that are just showing that there's a large number of short goals, which are those ones that what I call best practices, multiple buttons that you just process, which I totally understand. But also, luckily, no one adds in 0 goals, which is great. So let's have a look at our next slide. So this is about the goal creation, and I know SMART is a really annoying acronym and everybody's sick of hearing it. However, it's actually really good at helping you create goals. So SMART goals, for those who aren't sure, is around specifics of a goal. So specifically stating your goal, measurable. So you need to have some sort of mention of measure in your goal or how you plan to measure your success. Is it truly attainable? Is it relevant? So whether it might be relevant to, in this case, it says career or education, but we'll be talking about it specifically with medical goals of patients. And then time-based. So how long do we want to see this be done? So this is a sheet that I have for a lot of our support clients, etc., that a lot of the nursing staff will end up popping up on their room. So you don't have to frantically screen share. At the end, there's a QR code that you guys can scan, and you can download the PDF and print it and pop it in your rooms if that's what you'd like, or you can essentially whatever you sort of prefer. But essentially what this does is it shows us the specific, measurable, achievable, relevant and timeline-based goals. So we've got 2 particular patients here, and I've said for interest sake, we'll go with Mark in this one. So the specific patient in this case is Mark, and he wants to reduce his blood pressure medications down from 3 to 2. And we've had a chat to him and said, look, this is what we need to really be doing to improve your health, whatever that might be. It might be around diet, reduction of alcohol, smoking, whatever it might be. And in this case, is measurable. So Mark is going to have his BP that's going to be checked every 3 months. And then the other option is this truly achievable? Could Mark actually realistically get himself down off one of his antihypertensive agents? Is he morbidly obese, or is he actually like a BMI of 25 and otherwise completely healthy? And we just couldn't get this man off of his extra blood pressure medication. Is it relevant? So is it actually going to make a difference to their health? And if in his case, yes, because, he's kind of going closer to polypharmacy, he's getting, he's over, having his medication, he's sick of it, it's important for his compliance, feels better about himself, etc., etc. Then timeline is how long are we going to see to see the success? And in Mark's case, it will be about assessing the removal of one of his medications in 12 months. So if I had a look at another example here and putting it all together, and what the care plan's actual goal looks like is a decent sentence, and sometimes even more than one sentence. And this is the importance of making really good goals. Is in this case, I've said Jan, who's another patient in this as well, will lose 7 kilos before seeing her daughter in America in 6 months. So that is very specific. Okay, so you really cannot argue that is not specific to Jan. Jan will weigh herself on the 1st of every month for the next 6 months. So we've measured it, and we can see that this is going to be achievable. And then we're tying in the relevance. Okay, so in this case, Jan is a diabetic, and we want to see her improve her diabetes. So you've already got the measurement of her weight. So we're going to be seeing her weight reduce. If you really wanted extra amazing goals, you could also say that you want to see your HbA1c hit under 7%, under 8%, whatever it might be. But in this case, that particular goal really makes your care plan completely bulletproof. And that's the most important thing. And I think for a lot of GPs, there's not a lot of time to be able to do that, or there's not a lot of option to be able to do that properly. And I think as nursing staff and support staff that help us with our care plans, having those goals already, a little bit even more bulletproof from a Medicare point of view is so important. And so I recommend, tomorrow, the next few days, whenever you're going back to work, having a look and just trying it with one of your patients, just to see. You don't need to do massive changes straight away, but to see how, I actually can do this. And then you get really, really good. And then you can start doing them really quite quickly because, I'm going to check this, I'm going to do that. And this is my measurable, and it's relevant to their peripheral vascular disease, whatever it might be. Okay, so that is the process of the creation of the SMART goal in that sentence structure that I would put into my care plan. So this is a little slide here about who does it. So how do you do your care plans? Does the nurse do it? Does the DP do it? What's the process between those? And who, what's the better option? So, I mean, there are some GPs who definitely do not do any of their care plans, and they may not be particularly tech savvy. They don't have much time. They prefer it to be done by the nurse, whatever it might be. And then, so there's obviously some great pros to having your nursing staff doing their care plans. So it's really, really good to have complex and chronic patients seeing a nurse, not only for obviously getting a lot of the harder paperwork completed, but also a really good introduction to the MDT approach and saying there's a nurse here, there's the GP here, they're building that relationship and that rapport. And it's also good in the future to start thinking about with co-billing, and that can be a nurse's responsibility. So some of our nurses are incredibly good at finding co-billing options, whether that might be, hey, they haven't had a healthy heart assessment, that's also possible at this appointment. Hey, they haven't had an ABI, they haven't had XYZ, whatever it might be. And so having the nurse to look at it is another really great option. Some of our nurses also are fantastic at finding immunizations that have been missed or haven't happened yet. And for patients, they get done at that time. It's another awesome, great grab of preventative care. The cons of having nursing staff doing your care plans, I think the most common one for me is risk of losing the patient to follow up. So normally I'll say, I want you to come in and see my nurse. She's going to complete your care plan. appointment, and this is the reason why. And I suppose in certain patient groups that might be really difficult. So in the younger cohort, in the cohort with mental illness, etc., there's a lot more chance of not following up, and so that's another difficult thing. And also sometimes you may just have absolutely no nurse space to be doing care plans, or they are just absolutely booked with excisions or immunizations or flu clinics, whatever their time has been taken elsewhere. So obviously in the alternative is when the GPs are doing their care plans themselves. I do a lot of care plans myself. It's absolutely fine. I do also love a bit of technology, so I have a real art form down to it and can do it very nice and quickly and effectively. So the other good thing about that is there's no need for me to be waiting on nursing space if it's become an issue. If there's illness or we're having low staffing problems, whatever that might be, then I'm not needing to worry about that. So then I've also got quicker access to the rebate, and I reduce a lot of that loss to follow up. So in that young patient cohort, that's really clear cut. That might be my endometriosis patient, that might be my PCOS patient, whatever that might be. And then I can get that done pretty much within a recall appointment, etc. The cons are obviously you need to be pretty organized, and you really need to have your system perfected to be able to do it without sort of flustering and going, oh my gosh, I'd need 45 minutes to do that. If you have some GPs who are tech savvy and you think, hey, why don't you just try it, have a look? I do have a lot of resources online about care plans, templates, creation of templates, etc. Get them to have a look. The world is their oyster, especially in the world of AI now. And so it's just something that you can consider. Okay, so now I'm going to chat with you guys mostly about 10997 and 10987. So let's have a look here. So survey, this is the second survey, and I promise this is the last one. So if you don't mind popping it up for me, Jade or Helene. Perfect. So the first question is on reflection of your practice. Do you feel like you can accurately explain how you use 10997? Do you feel like you can say it about 10987? And then also there's two other questions there about the average GP at my practice would bill 10997 how many times per day? If you're not sure on that one, just give it a guess. That's okay. And we'll see what your responses look like in a few seconds. Okay, so sometimes or no, for 10997, a lot of people do not know about 10987, which is absolutely fair, which we'll go through. So GPs are billing 10997 quite low, even lower for 10987. Okay, so I hope from tonight you can get a bit of an idea of how to use 10997 and 10987. And so let's have a look on that now. So 10997 is an item number that funds up to 5 nurse-led monitoring and support visits per calendar year, okay? And that's for patients who already have a GPMP, a team care arrangement, or a multidisciplinary care plan. Okay, so you need to have an active care plan, and you need to have an active team care arrangement, and you also need to be having those 5 spots per year with the nurse and the patient. Now, in this particular case, what we'll be looking at is about what can I do with my 10997. So here in the left-hand corner, you've got what 10997 is, and that is for services performed by a nurse or an Aboriginal and Torres Strait Islander health worker. Again, mentioning about having to have the care plan or the TCA or the multidisciplinary care service. Now, the other thing is that your service must be relevant to your goals, okay, or mentioned in the care plan. So here's a list of things that I have claimed on 10997 in the last, I think it was the last 2 weeks from memory. So I was only little bits here and there. So have a look. So checking in on a weight and measurement for weight loss for your diabetic patients. So normally I think about getting my patients to see the nursing staff nearly every time they come and see me. Obviously there's those who would see me a lot more than 5 times a year, but on average, I do have a younger population of patients who, when they're seeing me, I think, okay, how am I going to access 10997 with this patient? So in this case, checking on weight and measurements for weight loss in my diabetic patients. So Jan in this instance that I mentioned before, checking how the diabetic patient is going administering insulin. So getting my nurses to show them about, changing the site, how's it looking, how have you found the insulin, have you had any hypos, etc. Checking in on medication compliance, a DAS21 for mood monitoring and progress in my depressive or anxious patients. Prolia, obviously, how many Prolia injections do your nurses do? I would say a lot. And that is absolutely available for your osteoporosis patients. They're really important. Even, if you haven't got a goal that's related to osteoporosis in that care plan, add in that goal so that you can access the 10997. Depot injections for patients with schizophrenia, an ABI that's been done for those at risk with peripheral arterial disease, Prevnar injections for my COPD patients, influenza vaccines for kids, influenza vaccines for anyone with a chronic disease, collecting information to support GP reviews or care plans. So if there's specific things that I've mentioned, I will often get that to be added through a review. So that might be chasing down letters from a previous specialist, or might be having a chat with the diabetes educator, whatever that might be that's relevant for them. If I've mentioned in the care plan, I'd like them to have a health assessment done in the middle of the year. That might be the over 75 health assessment. That might be the 40 to 49 at risk health assessment of diabetes, whatever that might be. And that's now a task that I've asked the nursing staff to be involved with in the care plan. So that claims a 10997 as well. Or that might be talking about lowering salt in my hypertensive patients in their diet and checking in on how he's going. So using 10997 is actually very easy. And I would say on average, I would see maybe, I don't know, today might have been 26, 27 patients, and not a hell of a lot. And out of those times today, I checked, I had done 9 10997s. Okay. And so that's a decent amount of billings that's happened over time. Over a year, that's a decent amount of money. So using 10997 though carefully is about it's not able to be used when you're creating a care plan. Okay, so a care plan needs to exist and it needs to be current before you can actually claim 10997. So it's not to be used for nursing staff to do the care plan. Okay, and you would have probably remembered a few years ago about the nudge letters of 10997 that we were getting from Medicare saying, hey, you're claiming it too much. Are you claiming it correctly? And the reason is because it was being processed on a day with the 721, 723, and they've kind of gone, oh, why is a 10997 happened on the exact same day? And this is why. Okay. So let's have a look at what the opportunities look like around how do I look out for my 10997. And anyone who's sort of done a Better Billing talk would have probably seen one of these before. And this is my little table of how do I make 10997 and care plans and health assessments make it work in terms of patients. And I've just put here that Barry's one of my patients, and I've seen him 5 times per year. And one of the appointments, I've done a care plan. So that's my obviously first appointment. Then he sees me 3 months later, and I booked him in with the nurse prior, and he's also had a health assessment done at the same time, whether that's with a nurse that comes to his house, or at the same time of having a healthcare plan. Having a review for he's having his 732 and also having a health assessment during that time. So he might have a whole hour with my nurse, which then also attracts the 10997. Then I've gotten my nurse to help me go through the medication review at appointment number 3. And they've also checked on his OBS because that's been important for us. We've been wanting to check how his blood pressure's going, claiming a 10997 at appointment 3 with the second review. Then he ends up seeing me for his license review, which is a private consult that he's got at appointment 4. At that point, I also get him to see my nurse for his Prolia injection. So there's that 10997. Then on appointment 5, he's had another review. My nurse has also done an ABI, which I've asked to happen because he's diabetic. I'm concerned about these things. And that also attracts another 10997. So if I had a look at the cost between if I did chronic disease, which is in the first column, and if I didn't do chronic disease with this patient, Barry. So Barry would pay me $400 if I didn't access any of the chronic disease item numbers, and the fees for me go to $400. But on the initial of the chronic disease column here, you can see that Barry's actually only paid $80 for his private appointment with me in appointment 4. The rest, however, has been Medicare funded, and it's approximately $1,300 versus $400 for essentially what we would be doing anyway, except with a bit more coordination. How do I actually find space for my nursing staff, and how do I pre-plan it? Is I am a very much a prepared scheduler. So I like to have a look at my schedule about 1 to 2 weeks ahead. And then I also have a view for all of my nursing staff, seeing what's available. And then I will try and match up appointments around the same time that my patient's coming in. So they'll see the nurse beforehand. It's also about sort of training your patients that, hey, I'm going to get you to see the nurse before you see me. And that's normally what I'm like. And they get used to that. They know, oh, yeah, the nurse is checking my weight again. The nurse is checking my blood pressure. They want to do this particular test that Dr. Ash had mentioned about before. Cubico is another option as well. I personally don't use it, but it's also helpful at really helping you find co-billing opportunities, health assessment opportunities, care plan reviews, etc. But another one which I really like, and I really consider that everybody has a look at it at least once, is Doctor's Control Panel. It's very cheap, very affordable, and awesome. I love my Doctor's Control Panel, and I don't think I would like my job half as much as if I didn't have it. And so there's also a platform there called Nurses Control Panel 2, which is viable through a subscription with Doctors Control Panel, and it is awesome and really helps nursing staff to just have a look at, oh, hey, they've missed a Prevnar. Hey, they haven't had that second Shingrix, or hey, you actually missed influenza vaccination, whatever it might be, or your Prolia is 4 weeks overdue. Oh my gosh. And it's a really great snapshot. So if anything, have a look at that at least once in the next week for me. So then let's have a look at 10987. So 10987 is a follow-up service that's by a practice nurse or an Aboriginal and Torres Strait Islander health practitioner on behalf of the GP for a patient who has received a health check. So particularly 715. So a 10987 is for a patient who has had a 715. It is claimable by all GPs, and district medical officers can also claim this. GP supervision is required, but you do not actually have to be on site. So if, for instance, the patient is following up with the nurse doing some specific follow-up and you're not there on that day, that is still claimable 10987 through the patient's regular GP. Okay, so that's the difference between 10987 and 10997. 10987 can be done without having to see the GP. 10997, there's normally interaction that's required by the GP to be able to bill that with another item number. So say, for instance, 23, 10997. But if, for instance, my patient is being checked for their blood sugar and I'm not on site, I might be somewhere else, then they can be then I can be claimed on my behalf at 10987. There is 10 claims that you can claim in a calendar year for 10987. And it also attracts bulk billing incentives as well. So specifically, a practice nurse is someone who is a registered or an enrolled nurse who's employed by the practice, and an Aboriginal or Torres Strait Islander health professional is one that's board registered and employed by the general practice or an eligible clinic. Now, 10987, the tasks that are related to that can be very similar to 10997. So it's got to be anything to do with the goals created with your 715. So if you've got a patient who is a florid diabetic and you really want them to coming in for their blood sugar check when they're unwell or when they're not eating well or whatever it might be, then that's one of your initiations. If it's the patient that's having issues with, recovering with eating disorders and they're needing to have their observations done, and that's part of their 715 assessment, that also can claim that 10987. Okay, so what we're going to do is put it all through together in the patient journey and see what this looks like from two specific patients. So this is our nurse here on the left, and then we've got two patients, which I believe one is Marcus and one is maybe Maria. I don't know. We'll check. But either way, they're fake patients with actual stories that we've kind of all seen these patients before. So it's Marie. Okay, so let's meet Marie. And Marie is a 41-year-old woman, and she identifies as Aboriginal. She's a single mum of two kids, with two are 10 and 4, and she works as a high school teacher. She has PCOS and had infertility, attempting to conceive the second baby, but obviously successfully did so. Her BMI is 33. So Dr. Marks is her GP, and Marie has come in for her 715 check, and it's going to be done before her next appointment with her GP. And so the issues that they've raised through that health assessment, the 715 health assessment, is she really wants to focus on weight loss to improve her fatigue, and she knows it helps her PCOS. She wants to have an STI check because she hasn't had one in quite a while, so that's one thing she really wants to do. She wants to have bloods. She needs her bloods done for her HbA1c, lipids, and ACR, which has been long overdue. She's now newly hypertensive out of nowhere, so she's 155 on 86, and her vaccinations, she hasn't had her flu vaccine. She's a teacher, and she knows she needs to have it done. So when you're thinking about future check-ins with the patient or future interactions with the patient, thinking about 10987 opportunities here. So weight check-ins for Marie, blood pressure check in 3 months, depending on what the GP might be doing, helping her with urine and swab collections, or the education process on that, and showing her how to do going to the bathroom, doing a high vaginal swab, or showing her which part of the urine you're after. So is it first pass? Is it midstream? Cycle tracking education. So that might be about educating her on, different apps, tracking apps for like Flow or the Apple Health app, on helping her track what her cycles are actually looking like, or that may be giving her influenza vaccination. So these are all items that are done in practice that would attract this number. And it's actually quite a decently paying number. So it's about $27 you get for a 10987 with your bulk billing incentive too. So, you're kind of looking in that, $33, $34 range. And that's quite decent, especially for, you've got your nurse's time that might take 5 to 10 minutes or 15 minutes. That's a decent use of the time. So then let's look at our second patient, and that's Marcus. And Marcus is a 73-year-old man. He does not identify as Aboriginal or Torres Strait Islander. He's a retired plumber and lives with his wife, Marge. He's a type 2 diabetic, and his last HbA1c was 7.7. He has peripheral vascular disease. He was a previous alcoholic, but he's been sober for 11 years. And Marcus has got a BMI of 39. So Marcus has come in for his care plan, and Dr. Marks is his GP as well, and she's asked for a care plan to be done before the next appointment with the nurse. So the focus goal for Marcus is aiming to reduce his BMI to under 35 in the next year, in the aim to reduce his diabetes risk around his HbA1c. He plans to do this by visiting a new dietitian at the clinic, and he also wants to walk 5 times a week. So having a look at the nursing tasks in follow-up for 10997 here is his weight, his blood pressure check-ins every 3 months, and also at reviews. Maybe that might be 6 monthly bloods, or providing it with him, or explaining to him the fasting rules around the blood tests that he needs to get. That would be in his tasks. He's got, his dietitian 3 times a year. He's walking 5 times a week. And ABI is also, that's been done here in the tasks. So that's another nurse-initiated item that attracts a 10997. Then his vaccinations. Has he had his Prevnar? Has he had Shingrix? Has he had his influenza vaccine? Where is he at with his COVID? Does he have Prolia? That he's also osteoporosis as well. So these are attractive items. These are all attracting a 10997 relevant to his care plan, because one of the tasks is vaccinations and Prolia, if that's the case. He's seeing his podiatrist, and then he's going to have a vascular review at some point next year. So like I mentioned here, the options for Marcus of 10997s here. Other things I also mentioned, so checking in on his exercise tracking and getting to the 5 times per week, helping him maybe find something else if the walking is not really working, checking his blood sugar, teaching about counting carbs, or the 699 health check that you might do at one of the other reviews at the same time or at another time. And so these are future options that you can look for, those 10997 ideas. Okay. So that is, okay, 40 minutes. I talk for 40 minutes nonstop. So this is a little bit about questions. Now, this QR code that's right here is the SMART goal format that I was mentioning in the PDF. So you can actually scan that there, and it's just a downloadable Canva link, which I've made it on. You're very welcome to use it, print it, laminate it, put it wherever you like if you'd like to try it, just to really help you guys sort of reduce the burden of trying to figure out how do I make my goals and what sort of things should I be doing. I will go through the questions in the meeting chat. So if anyone wants to add some questions in, go right ahead now. So I've got, okay. How about chronic back pain without radiology reporting, or morbid obesity without any other conditions? I'm never sure about these ones. Okay, so the chronic back pain, like that is a chronic condition. If it's happened for more than 6 months, they've got chronic back pain, they're seeing physio, they're seeing those sorts of patients. Just because there's no radiology doesn't mean it's not there. And I think that's absolutely fair. Morbid obesity without any other conditions is not as simple as having a care plan, unfortunately. So quite often in these cases, those patients fit the criteria for metabolic syndrome. And in my case, I find that's the case, and that's much easier for processing in terms of a care plan, because you've got the diagnosis, you've got a very clear criteria, they fit the criteria, and you go from there. So, but straight obesity is unfortunately never an option. Can we claim a TCA 723 with 3 GPs and 2 specialists, no allied health? No. So the point of the team care arrangement at the moment is about accessing rebates for allied health, and none of them are allied health, and so therefore you can't claim the TCA. What happens when someone is eligible for a 721, 723, however, they do not have a third provider? Okay, generally you can still do a 721, right? So you can still do a care plan. You don't actually have to do a TCA with every care plan. That's absolutely, you don't have to. And there are times when I will just do a 721. However, if they don't have a third provider and you really want to do a team care arrangement, I mean, you can do a few options here. If there's other, other GPs in your practice that may particularly do skin cancer, you can refer to them as their skin check GP. Another option is getting the pharmacist involved for a medication review, optometry added in, etc. Just have a good think about it. And quite often they'll say, oh yeah, no, I always get my eyes checked at Specsavers. That's where I go every year. Or I get my hearing checked at this place down the road every year. And so these are providers. So see if you can. Otherwise, worst comes to us and you just do a 721, that's okay. Should a care plan be GP initiated or nurse initiated? So, I mean, this ultimately it should be GP initiated. So the GPs are ultimately responsible for the care plans and the creation of a care plan. And so ultimately they're billing it, and it's their responsibility to make sure that it's done correctly. So just, I mean, there might be some GPs that say, oh, the nurses decided who can get care plans, etc. It's not technically the case. It needs to be the decision that comes from the GP, and ultimately you're doing that on their behalf. Can MBS 10997 for the nurse and 23 for the GP be claimed on the same date? Absolutely. That's what I do a lot. And that's absolutely fine to claim the 10997 role that's been done for me beforehand, and then the 23 for seeing me. Then my understanding has always been that a 10997 couldn't be claimed at the same time as claiming GPMP, TCA, or health assessment items. Has this changed? So that's right. You cannot claim a 10997 at the date of creation of the care plan. Health assessment items is different. If it is important for your goal to reach your goal in your care plan that you said, I'd really like the nurse. We at our practice have a nurse that goes out for over 75s to their house for their health assessment visit. And that is amazingly, it's awesome. And so sometimes I really want to see how the living situation is, and having my nurse go out there is a really important part of, say, falls reduction, etc. And so if that's relevant, I will claim a 10997 in this particular case. But the creation of the care plan, you're right, you cannot claim a 10997. Is this mandatory that TCA signed by the allied health, or can we bill without a TCA signed? So the thing with this, like I'd mentioned before, the Medicare system had changed its requirement on 723, where the signature had disappeared. The need for a signature had disappeared. It was just taken away from the explanation. Previously, it was always about having it signed, but now that has gone. As of what we plan to be as of July is the team care arrangements will be completely gone, and that won't be an issue for you. However, at this stage, from my understanding, and I recommend that you have a read of this and have a look at it yourself, is that you do not need to have a signature return for a team care arrangement to be billed for at the moment. However, a lot of practices have been doing the waiting for signatures for years and years, and you don't want to change anything when we've got some changes coming up anyway. However, check the 723. You'll be able to see that once there was hold for signatures and you need your 2 signatures and your 2 care providers. However, that has since been removed. Perfect. I think that is all of the questions in the chat. Is there anything else that anyone else would like to ask, or anything else before we wrap up?
I'll just take this opportunity to remind you about the evaluation, if you could take the time to fill that out. And Ashley, thank you once again for a brilliant presentation. Okay, so there's no more questions from anyone. We will wrap the webinar up, and thank you everyone for attending, and thank you again, Ashley, and we'll see you at the next one.
No worries. See you
Bye,
later.
everyone.
Bye.